Hello, everybody, and welcome to this masterclass where I'm going to shed some light on your own lab tests that you may have from your own general practitioner or primary care physician, and some of the differences between how we look at lab tests in allopathic Western cookie cutter conveyor belt medicine, and how we look at lab tests in functional medicine. So there are several differences, and you're going to find that out. So I'm just going to share my screen. Oh, interesting. Fair enough. Okay. Now I know there's a special way of doing this. I'm just going to stop sharing for the minute while I get good old PowerPoint just right. That will do nicely. So excellent. Well, that's new. It's only letting me share my desktop, not just the PowerPoint. So you can see the PowerPoint now, can't you? But if I were to look at presenter view, you're seeing the whole screen, aren't you, rather than just the bit?
We're seeing your the next slides. Yeah, the presenter view. Yeah.
Okay. But well, we'll just have to not do it that way then. Here we go. Hi there. So today we're going to talk about some of the nutritional gems that are hidden away in your blood tests and how you can get some of the critical tests that you may not normally be able to get hold of, but also some of the things that you can get discover within the ones that you may already have. So in many countries you have an annual blood test. Certainly in America that seems to be often the case, and if you have some forms of health insurance you may have that. Oh, that's exciting, isn't it? There we go. So some of the problems that we have with our blood tests is that when you are talking about the traditional Western medicine, where we're trying to keep things as inexpensive as possible, which you may also want to do if you're doing things privately as well, if you're paying for the doctor's time or your practitioner's time and the lab tests themselves, you will understand why any system like a healthcare system that's based on insurance or one that's based on taxation will need to keep things inexpensive. But that means that your average lab test is just checked through at a rudimentary level. Doctors like myself, so I'm Dr. Ali, I'm the midlife medicine woman, and I help women and men to balance their hormones and to get optimal levels of their hormones and to get optimal health and to really empower themselves into a better state of health. And to take back ownership of their health. And that's one of the things that I think is difficult at the moment, in that we so often have a culture nowadays in Western countries of handing over responsibility for our health to the doctor and just doing as the doctor says. But I'm here to tell you that that's not necessarily the right thing to do. And I'd recommend that you start to take back ownership of your health so that you are knowing more, understanding more, And you can do that with some of the things that I'm going to share with you today. We have the internet now. You can research far more. And it's difficult. I, as a doctor, I have a foot in both courts. I have my functional medicine practice, much of which is done in the role of a health coach, where I'm not diagnosing or treating. I'm sharing information and supporting people. And that's really wonderful, because the diagnoses that medicine is based on are they are very much based on a selection of symptoms, and they're not necessarily the right way to go. On the other hand, I also spend time in the United Kingdom's National Health Service, or NHS, where we just have we only have 10 minutes a patient. I may have to look through 200 or more blood tests in the space of half an hour. And so you don't have time to look in the sort of depth that I'm going to share with you today that it is possible. And that depth just isn't possible in the NHS. It's just not. And it's not the doctor's fault. So I'm not here for you to go to your doctor with some lab tests in hand and saying you didn't spot this. It's to give you some understanding of these two ways of working being completely different, and the NHS way isn't perfect medicine, but it is an effective way to bring medicine out to the entire population, including people that can't afford to go privately. And that, I think, is a good and important thing. So today we're going to talk a little bit about why I'm passionate about this side of things. We're going to talk a lot about cardiovascular disease. And my mom had a series of heart attacks, a coronary bypass graft, and she had peripheral vascular disease first before she was diagnosed with heart disease. And she had vascular dementia at the other end, although she actually died from another heart attack, which is probably her third or fourth, in June of this year. And it's just interesting to reflect that there are keys at the beginning of this that can help us with this, with trying to be a detective for your own health and try and see what's the root cause of these things. And one of the things that we're going to look at, which I'm particularly passionate about, is insulin, diabetes, pre-diabetes. Now, in traditional systems, we are now tending to pick up pre-diabetes at a certain level, and we're going to go through the levels that involve later on in today's masterclass. But we're still not picking it up early enough. But then again, I understand why not. So one of the reasons why the NHS and similar systems will skirt over the surface is they don't want to panic people. They haven't been taught to empower people. The vast majority of the population, so with these systems that are bringing healthcare to the entire population, that's including the people who are never going to lift a finger to support their own health. They don't see the reason to, they don't want to, they'd rather carry on living their unhealthy lives and having fun, in inverted commas, even if that's at the expense of their health at the other end. So that's why you can't have this functional medicine approach for an entire population, not as things stand at the moment. But the reason I'm passionate about diabetes is with my own family history. So first of all, I remember when I was a little girl that we went to see my aunt and uncle on the Isle of Wight. They were farmers, and my aunt was blind. And my aunt was blind because of diabetes. And I still have the memory of their kitchen and their Aga with a big saucepan of boiling water where she was sterilizing glass syringes for her insulin and reusing needles because disposable needles didn't exist then. And so the needles were blunt. We know now that reusing needles leads to an irregularity of the way that the insulin is absorbed into the body. So we don't recommend reusing needles. That took me a long time to persuade my mum not to do that, even many years later. So Auntie Ida had diabetes, was blind from that. She died when I was still very young, maybe when I was 11 or something. The next thing regarding diabetes that happened to me was that my brother was diagnosed with type 1 diabetes. We're not sure what my aunt had, probably type 1. So my brother Robert was diagnosed with type 1 diabetes at the age of 7. Now, what we know in functional medicine is that every scenario is multifactorial. There are many different factors that contribute to that circumstance happening. So often type 1 diabetes can be triggered by a viral infection. In this case, there was extreme stress going on in the family as my parents were splitting up. So that was a contributing factor. And one of the things that we do in functional medicine that we certainly don't have time to do in traditional medicine is we look at the root causes. We look at what happened when your mum was pregnant with you, whether you were breastfed. Even if you're 70 now, we're looking all the way back at this time, as well as at genetics, to really get an overview. And we also look at stresses throughout your life, because stresses are often triggers or antecedents or things that maintain ill health. So my brother became type 1 diabetic, which is autoimmune diabetes, at the age of 7. That's the one where you're not producing any insulin at all. Your pancreas is packed up. The beta cells just aren't functioning. And they tend to be on insulin for life. Insulin is life-saving for them. I think it was Banting and Best who discovered insulin in the 1920s. And then my favorite aunt, Auntie Beryl, who was my godmother, she developed type 2 diabetes when she was in her 40s. And she moved in with my mum. Their plan was to run a B&B together, and they were going to live together for the rest of their lives. But unfortunately, she became very unwell after only 18 months of them living together and developed multiple organ failure. Now, we have seen in recent years with the certain infections that's been going around in the last 3 years that we've seen how diabetes and insulin resistance, which is what precedes diabetes, impacts our immune system. We've seen how that affects our ability to withstand, to be resilient against infections, and how badly we will get infections. So many of the people in the last few years that were admitted to ICU had a vitamin D deficiency and insulin resistance and obesity. Those combinations are not very good. So my aunt died in her early 50s, I believe. My brain's a bit foggy on times for that. And then my mum developed diabetes. Type 2. So type 2 is the one that people associate with obesity. And certainly it's very much lifestyle induced, but these things have many different factors. So, and even the way we eat has many different factors. There's our genetics, there's the way we've been brought up, and there are things like emotional issues that affect whether we do comfort eating, etc. And diabetes is something that is preceded by pre-diabetes, what we call impaired fasting glycemia. But what I'm going to share with you around levels and around normal ranges and optimal ranges, which are two different things, is that we can actually pick up if we've got a tendency to diabetes at an earlier stage. And if you have a family history like I have, and if you have developed in your 50s a bit of a midriff as I have, I know that I have insulin resistance, even though I don't have pre-diabetes in NHS terms. So that's why I'm passionate about heart disease, diabetes. Here's my mum with a picture of my son behind. She died in June and she developed the peripheral vascular disease, which is blockage of the arteries in the legs. Then when she went in to have that unblocked, cored out, her heart rate went down and her temperature went down and her blood pressure went down, and it was because she had hypothyroidism. So she had an underactive thyroid, that was when that was diagnosed. Then she developed heart disease. So she had a heart attack in 2009. I remember she rang me instead of the ambulance when I was driving to work. So that is embedded in my memory. And then over time, she had valve replacement. She had coronary bypass graft. And she had, they could only do 2 of the arteries, not the third, because she'd had her varicose veins stripped in her 30s or 40s when we did it willy-nilly. And I always counsel patients that you really need those veins. You might need them when you're 70 or 80 for your bypass graft. So don't have surgical intervention unless you need to. So coronary heart disease, ischemic heart disease, angina, and heart attacks, those are also furring up of the arteries, this time of the coronary arteries that are in the supply the oxygen to the muscle of the heart. So they're embedded in the muscle of the heart to give enough oxygen for that regular propulsion that that skeletal muscle of the heart is using all the time, every day. And then she developed dementia, which is what we call vascular dementia or multi-infarct dementia, which is caused by, again, a stroke, basically furring up of the arteries in the brain. So all of these things contribute to, that they are caused by the same pathological situation of furring up of the arteries. And I'm going to talk a bit about some of the ways you can pick up these things early and prevent them from becoming more of a thing. So first of all, we're going to talk about some of the critical tests that can help you detect disease before it kills you, before it affects you. And there's a lot we can do with this respect. And there are some hidden clues sitting in your blood tests, even in the blood test your GP has already done. So as a functional medicine doctor, there are a lot of different tests that I can do that aren't covered in the normal run of things. There are also, and I'm going to cover this, there are also tests that GPs know how to do, but they're not allowed to because of the rationing that does exist in the NHS. So they're very, the systems try their best to stop me requesting a vitamin D level, for example. That gives you criteria you're supposed to have if you're doing this test. And chronic fatigue, for example, is not on that list. But I have cured many cases of chronic fatigue syndrome and fibromyalgia, because vitamin D deficiency causes chronic pain as well, just by getting people's vitamin D levels, not to the normal level, the NHS normal level, but to the optimal level, the level that's really going to make a difference. So my passion comes from that family history, but also I've always had an inquiring mind. I've always wanted to know the way things work right from the start. I grew up on a farm. I was passionate about wildlife and animals, and spent a lot of time just sitting in the hedge, watching voles and shrews around me, reading a book, and just immersed in nature and surrounded by nature spirits. And it's that connection to nature, which is another reason for my passion for functional medicine and for helping people to heal their health naturally, without pharmaceuticals, without surgery, but in a more empowering way, where you're not waiting till you're sick, you're preventing that sickness developing, you're being more proactive about your health. And this is a very time-consuming way of doing medicine. But when I first heard, I think I probably just qualified. Maybe I was doing GP training when I heard all the news about the sexes of the fish changing because of the hormones in the water from the contraceptive pill and from HRT. And I was shocked, but I was even more shocked because there was no change to prescribing. And again, I've talked a little bit about the National Health Service and Western medicine having to pander for a whole population, including the people who weren't prepared to be proactive about their health. And so the assumption is, just as the assumption is with diabetes, and I remember one of the doctors in my practice saying this to me, that there's no point giving intense lifestyle advice to diabetics because they're never going to follow it. Likewise, it's so important for women to be able to control their lives, which I agree as a woman, as a feminist, as somebody who wants us to have control of our lives. So the contraception is so important, reliable, good contraception. And the assumption is that because natural family planning is intensive and takes attention, most people won't do it correctly. There's something to be said for that. It's true. Most women who want coming in to see me who opt for contraception aren't going to pay attention to that degree. But on the other hand, I certainly don't have time to explain natural contraception to people. And so the expectation is on both sides that a form of contraceptive pill or some other contraception is going to be used. So my passion is around helping us to heal our bodies naturally and avoid medications wherever possible, avoid the need for medications by controlling our blood pressure naturally, by balancing our lives so we don't get so stressed that it puts our blood pressure up and gives us a stroke, starting at the root cause level. And part of that is immersing yourself in nature and keeping fit. And that connection with nature is somewhere that I always come from and I always come back to. And I get out in nature every single day. I do my yoga outside every single day while I'm walking my dogs. And I encourage you, even if you're in a flat, when you see a spider, instead of killing it or putting it out the window, just sit with it for a moment and remember that that's nature. You've got nature where you are, wherever you are, and you can enjoy it. And I would like you to have vibrant hormonal health. That's where my aim is. So I'd like you to think for a moment and write in the chat, if you will, what's one thing you'd like to walk away from tonight knowing or feeling inspired to you? What's one change that you would like to be motivated to make after today's talk? Do you have any questions that you specifically have at the back of your mind around blood tests and around natural medicine and around your health, or that of your parents? Another element of what drives me is in NHS general practice, it's not unusual to see patients on 19, 20, even 25 different medicines on their repeat prescription list. And people are shocked when I say that. They don't believe it. But believe me, you may have spotted it in your own parents' medication lists. It's completely normal to treat each diagnosis in isolation from the others. So there's one set of medicines for this and another for this, and then these ones cause, say, they can cause gastric ulcers, and so you give them that to prevent the gastric ulcers. And then, say, for example, we can have somebody who's on aspirin or an anticoagulant. So now lots of people with atrial fibrillation are being put on anticoagulants to help prevent stroke, which is a really important thing for us to prevent, because it's, nobody wants to have a stroke. And it can prevent the vascular dementia I was talking about as well. But then they go on to omeprazole or lansoprazole, what's called a proton pump inhibitor, to prevent the anticoagulant causing a stomach ulcer or anti-inflammatories causing a stomach ulcer. And then that causes calcium and magnesium deficiency, protein deficiency, which we'll come to later, which in itself will cause more problems. So the calcium deficiency can lead to osteoporosis and to vascular and nerve dysfunction. Magnesium deficiency can cause leg cramps and migraines, and it's very, very common. And magnesium is needed for so many different chemical reactions in the body. So Vicky, so TSH is still out of range despite being on levothyroxine and doing other things to keep my thyroid healthy. So it's about 4. So we're going to come to that in a moment, Vicky, because TSH of 4 is considered normal in Western terms, but abnormal in functional medicine terms. So it's a perfect example of what we're talking about here. So what would you be doing with your life if you had truly vibrant health and hormone balance and you were feeling truly well? Is there anything different about how you'd be living your life and how you'd be planning your future if you knew that you weren't going to suffer from these debilitating diseases in the future? Do type in the chat if you've got anything to say about that. So to get the most out of this training today, I'd like you to turn off your cell phone, although you're very welcome to invite more people on Facebook or text if you want them to join us. Turn off Facebook. And this is the registration page for today's talk. And I'm going to be doing it again on Saturday. Stay focused. So it's very easy to be distracted, but I'm going to be discussing some quite heavy stuff here. So we do need you to stay focused and not get distracted onto other subjects. And open your mind and heart and listen with an open mind and heart to what I'm going to share with you today. So I do need to put in a medical disclaimer. And in this role, I am not your doctor. This is not medical advice. And it's not intended to replace a one-on-one relationship with a qualified healthcare professional. And we encourage you to make your own healthcare decisions based upon your own research, informed by things like this masterclass today, and in partnership with a qualified healthcare professional. It's provided for informational purposes only. There's no guarantees, representations, or warranties. Okay. So what's the problem with normal lab values? I've explained a bit about why we have normal lab values, why medicine is generally based on normal lab values. So let's look at some examples here. So the glucose is done in US scale here. So we'll do something different. We'll look at, say, the creatinine. So the NHS or Western medicine normal level is between 0.5 and 1.2. But if you want optimal health, it needs to be much closer. It needs to be 0.7 to 1.1. It needs to be that much narrower. So when we have a normal range, what they are saying is that there's the mean average of all the levels when they've looked at a population, okay? And then there's a bell-shaped curve with most people at the mean level, and some, and on either side, some will be lower than that average and some will be higher than that average, and they cut it off at 95%. So what's considered abnormal is anybody with a level that's lower than 2.5%. The lowest 2.5% of the population and the highest 2.5% of the population. But that means it's based on average health. And when you look at people in the street today, I don't know about you, but I don't want to have that level of health of your average person in the street. Most of them are walking around with headaches, brain fog, overweight or obese, joint pains, heartburn, and lots of different things like that are just stopping them from really functioning at their best. And so I want to share with you that if we start to use functional levels, as I say, it's not about blaming your doctor or telling your doctor that you want them to treat that to functional levels, because they can't, they don't have time. But a functional medicine doctor or a health coach or somebody who is you're working with in a more close way will be able to help you to do that. So let's look at US versus standard international, because glucose markers are so important. So if we look at in the UK, the minimum and maximum here, Vicky, I'm not sure whether glucose in Australia is using the standard international or the US units, probably SI. Certainly Canada uses these units. So when we look at blood sugars, when someone's pricked their finger as a diabetic, we're looking at 3.61 to 6.11 is considered the functional range for fasting glucose. Although in fact, we used to say you're not diabetic until it's above 7. And then the US, they use a different unit here, milligrams per deciliter, rather than millimoles per liter here. So optimal health, you want it actually to be between 3.6 and 4.9. So you want it quite a lot closer. And then the HbA1c, which we're going to talk about in a bit more depth later, the HbA1c or hemoglobin A1c is measuring the amount of glucose glycosylated red blood cells. So red blood cells that have got a glucose molecule stuck to it, which is an irreversible change. And the red cell circulates around with the glucose attached to it for 3 months. So the HbA1c looks at the blood sugar on average over a 3-month period. And again, the lab minimum and maximum is 29 and 41 for normal. Then 41 to 49 is what we look at as pre-diabetes in the National Health Service as an example. But then if we actually want optimal HbA1c, it needs to be between 26 and 31. And I know mine is 33. So my GP is never going to say I've got an insulin resistance problem, but I know I have. And all of those people I see who are wandering around thinking, well, why have I put on weight? Why am I feeling thirsty? But especially the weight gain, it's actually because they're in this range where they wouldn't be recognized as being abnormal in NHS terms or in Western medicine terms, because we're waiting until it becomes so bad that you're getting to this level 41 before we do anything about it. And even at 41, 42, 43, we often don't do much. We are referring to pre-diabetes groups, but their lifestyle advice isn't as pristine as you would get from functional medicine for sure. And it's not going to, it's just to prevent a sort of really that level. That's okay, Amy. It's good to have you here when you are able to. Thanks, Vicky. Yes, you know, it's the same would be over here. People wouldn't have their blood sugar checked unless there was a reason to. It's how it is. So looking at things in another way here, I'm just going to close down my name so you can see. So we've got ideal here, insulin resistance and metabolic syndrome and diabetes. So again, this is showing these levels where we've got fasting glucose. Again, this is US version. So fasting glucose at a certain level, triglycerides at a certain level, HDL, which is the good cholesterol, and incidentally, cholesterols are also, they have funny units in the US, and I didn't have time to recreate this slide using UK and standard international units as well. The slide was getting crowded. And then fasting insulin, which we never measure in the UK unless you're a functional medicine doctor, but it's very useful for picking up this level of insulin resistance. And then the HbA1c, which so 5.3 to 6.5% we would consider normal in Western medicine, and more than 5.7 is considered metabolic syndrome and diabetes, higher than that usually. So it's very interesting when you look at this progression. There's ideal 4.5 to 5%, insulin resistance 5.3 to 6.5%, metabolic syndrome greater than 5.7, and diabetes greater than 5.7. Metabolic syndrome is a syndrome where you've got insulin resistance, you're getting weight gain, your blood pressure goes up, and you've got hypertriglyceridemia. So you get dysfunction, you get dyslipidemia, meaning a dysfunctional lipid profile. So you get too low HDL levels. In our units, we want the HDL to be greater than 1.8 ideally. And the lower the HDL is, the high density lipoprotein, which is protective of heart attacks and strokes. It helps to reduce, it improves the flexibility of the cell membrane. So it's really helpful. So there's the HDL and the triglycerides, which are the worst of the bad cholesterols in a way. So let's look at some of the blood marker categories that we're going to look at today. There's, first of all, nutrient imbalances. There's markers for cardiovascular health. There is blood sugar markers, anemia markers, and immune system imbalance markers. Now, there are lots more beyond this, obviously, that we're looking at in blood tests. You can look at liver function and all sorts of things, kidney function in more depth than we do in this talk, which is going to take a while because we've already had 42 minutes. And I've got messages on Facebook Messenger, probably people who've been trying to get in. Okay, good. Haven't been able to join. Can't find your email. Okay. Just going to quickly have a look and see if I can pick up. I'm going to, for a moment, stop the share and restart it again. That was one of the bits that I closed. Aha. There we go. Right. Bear with me. Da, da, da. Sing among yourselves. There we go. Yes, that's the thing with, you've got to try and find a way to get everybody in, and doesn't always work. Right, and continue share screen. So looking at the 3 important blood marker categories, the 5, we're going to go through these in some depth. So we might be here some time. Nutrient imbalance markers. So there are lots of markers of nutrient imbalance that people don't recognize, even GPs don't recognize. So the information I'm going to share with you today is the things that I have discovered through my passion for functional medicine and through nutritional endocrinology training, which is using nutrition to balance hormones, which is what I'm passionate about. And I was so grateful to bump into my mentor, Dr. Rita Marie Lascalzo, who some of you know, who has taught me so much that I didn't know before. But let's look at vitamin D to start with. So vitamin D, incidentally, I think in the UK, we use slightly different measures because I think we're measuring 2 forms of the vitamin D, not just the one. So here we have in the US terms, the lab normal is the minimum is 32 and the maximum is 100. In NHS terms, when I look at NHS lab results, that what they call the normal is 50 to 200. Functional or optimal ranges, in America, they would say 70 to 100. So you can see you're aiming for a much higher level. And I aim for 70 to 200 when I'm, and I explain that to patients. That's one thing I do have time or make time to explain to patients about getting their levels optimal. But I do explain that once it's in NHS normal range, the NHS is not going to pay for your vitamin D supplements, but you shouldn't be depending on them anyway. Supplementation needs to be part of your health insurance. And we're lucky in the NHS not having to invest and insure ourselves against, for major operations like in so many countries. So we're lucky the NHS is there, but don't rely on it for optimal health. It's there to keep everybody at a minimal level of health, really. So when you get your vitamin D result, if you're in the UK, you want it to be between 70 and 150, 70 and 200. Over 200, you can get vitamin D excess symptoms. So it's not good, but we certainly need it higher than 32. And sometimes, I've seen GPs pass a level of 30 as normal and even less than that. Once I had a patient whose vitamin D level was 8. Obviously, she had chronic fatigue and fibromyalgia, and it recovered. But it's a slow process with things like thyroid and vitamin D. It's going to take you a while to get your levels up. So let's look at a vitamin D balance plan. You want to reach your optimal range. In this case, that's US units, 60 to 100, or in UK units, you want it to be 70 to 200 for your results. But we're still using the same dosing guideline. So if your vitamin D level is less than 20, you want to be taking 20,000 units every day for 6 weeks and then retest, or 20,000 units a day for a month, and then 10,000 units a day for 2 months, then retest. Now, if you're getting the testing done on the NHS, you won't be allowed to recheck it for 3 months. Often you won't be allowed to recheck it then anyway. But when we're doing high dose replacement like this, we test at 1 month for bone profile, which is checking that your calcium levels haven't gone too high with that vitamin D replacement. And then at 3 months, we check the vitamin D and the calcium. So you can ask for that to be done if you are replacing at a high level. If your vitamin D level is 20 to 30, you want to be taking 10,000 units a day for 3 months and then retest. If your vitamin D level is 30 to 40, you want to be taking at least 6,000 units for 3 months and then retest. And then if your level is more normal in NHS terms, 40 to 60, The NHS will say that's normal. You don't need to worry about it. But I recommend that people take 2,000 to 4,000 units a day. Often I recommend 4,000 units in winter, 2,000 in summer, when you're in a situation where people aren't going to get it rechecked. It's actually not very expensive to get a recheck privately from a finger prick test that you can send off for. It's maybe 20 or 30 pounds. So well worth doing that. Genetics go into this too, though. So you may find that, and different people need different levels. So although we've got these guidelines here, some people will not come up even if they're taking 10,000 units. And other people will come up more quickly, and you need to make sure that they've not gone too high. So you don't want to be taking these levels of 20,000 units a day for long without rechecking. And then if your vitamin D is 60 or above, if you are living in a northern climate or a southern climate, in Vicky's case in Australia, you want to be taking 1,000 to 2,000 units a day in winter, and on days when you don't get out in the sun for at least 30 minutes, and retest in 4 to 6 months. If you are, it may be worth you getting it checked in winter and summer and writing down what time of year it was, because that will also vary your results, because of course vitamin D is the sunshine vitamin. So vitamin D, you produce vitamin D from contact with the sun. However, it's interestingly, even with Coast Guard, people working as Coast Guards in the Australian Gold Coast, they still had vitamin D deficiency, because of course, when we are exposed to sunlight, we sweat, and it's the sweat and the microbiome, the bacteria on the surface of the skin, that help produce the vitamin D, and we go in and wash it off. And so we find that we very often are our own worst enemies when it comes to our vitamin D production, as well as staying out of the sun and putting sunblock on for fear of melanoma, which is, of course, it's very important, but you do need some unsunblocked sun exposure, because vitamin D deficiency gives you a higher risk for all cause cancers, all types of cancers, than the risk of melanoma from not having the sunblock on. So as with all things, it's getting the balance right and making a decision for yourself, being as well informed as you can be. And there isn't one right answer. So I'm not giving you one right answer either. And then there are methylation nutrients, vitamin B6, B12, and folate. These are the B vitamins. Folate is B9. So these vitamins are really important for our methylation. Now, I know that's a long word. Many of you will have heard it. There's been so much talk since the human genome was studied about MTHFR, which is one particular area of the chromosome, an area of genes that is particularly important for liver metabolism, so the way we detoxify things. And we can pick up whether there are deficiencies of these through the blood tests. So some of the methylation blood markers, for example, are homocysteine, and then the mean cell volume, MCV. If the red cells are large, it usually means that there is folate or B12 deficiency. It can be a sign of alcohol excess as well, but that's really because people who drink too much to that degree tend to not eat properly, and they tend to have a folate and B12 deficiency. Methylmalonic acid in urine or blood is a more accurate way of measuring B12 levels than the serum levels. So here we've got the serum vitamin B12 here, which is what we do in the NHS, but it isn't actually a good way of measuring it, because it's not measuring the B12 available to the cells. And then we've got folate and metabolites. Oh, it's got 2 messages. Oh, that's all right. That's not an important message. Right. I know I told you to turn Facebook off, but I've left mine on in case of people like Anna not being able to get in. So Amy says, my local NHS lab reports vitamin D 25 to 50 may be sufficient. Yeah, that's what all of our GP labs tell us. 25 to 50 may be sufficient. So it gets marked as satisfactory, not flagged as being low. Absolutely. And yeah, I've seen that so many times. Yeah. Okay. Yes, you're right. You're right, Sarah. A lot of important emails end up in spam or junk, or I've even got something called quarantine, where I actually have to log into a website to retrieve important emails. It's all very well them trying to, the email providers trying to make our life easier by us not having too many emails to read. But when we've actually wanted them, that's a challenge. So vitamin B6 markers. So signs that your vitamin B6 may be low include low levels of some of the liver function tests. So these are the liver function tests, the aspartate transaminase, alanine transaminase, I think that's AST, gamma glutamyl transferase, and alkaline phosphatase. And interestingly, as a doctor, I've always been taught that raised gamma GT is a sign of alcoholism. And if somebody says, no, I don't drink, then you sort of assume they're lying, which is just the way the NHS doctors are trained to think. When I did the functional medicine training on toxins, any chemicals can cause this. So a raised gamma GT may actually be iatrogenic, i.e. caused by doctors, caused by some pharmaceuticals that we've prescribed, or it could be toxins in the environment. But anyway, we're talking about low levels of these. And generally speaking, if these liver function tests are low, as a GP, I wouldn't bat an eyelid. I would just pass it as normal because we're in such a hurry. We've got so much to do in so little time. But in actual fact, it can be a sign of vitamin B6. MCV, MCH, and MCHC. So this is the mean cell volume, the mean cell hemoglobin, and the mean cell hemoglobin concentration, all found in the full blood count or complete blood count, CBC as it's called in the US, hemoglobin and the hematocrit, and red blood cells. So these can all give us shed some light onto whether there's a B6 issue going on. High levels of iron and the red cell distribution width, RDW, can also be a sign of B6 deficiency. And then B2, which is thiamine. Now, this is classically deficient in alcoholics, so much so that even the NHS allows prescribing of thiamine replacement in alcoholics, because without it, they get a special type of dementia called Wernicke's encephalopathy, and and Korsakoff syndrome. But markers for B2 include the anion gap, which is look at the acidity in the blood, fasting glucose levels, oxygen, carbon dioxide levels, hemoglobin, hematocrit, and LDH, which is lactate dehydrogenase. And then vitamin C markers. So who'd have thought you could tell what's happening with vitamin C from a normal blood test? But if the alkaline phosphatase is high, the red blood cell numbers, or the mean cell volume, the mean cell hemoglobin, and the mean cell hemoglobin concentration, that can be a sign that vitamin C levels are high. And low levels of hemoglobin and hematocrit can also be signs of that. So indirect indicators of minerals in the serum. So we're often using indirect ways of looking at things. For zinc, if there's low alkaline phosphatase or low white blood cells, molybdenum we can pick up from the serum iron and the uric acid. Selenium can be especially a sign if there's low free T3. So Vicky with her thyroid issue, selenium is crucial for vitamin, for the conversion from T4 to T3. So it may well be, if you do my thyroid course, Vicky, when I produce it, the thyroid is so much more complex than we give credit to. And the TSH can be raised even if the T4 is normal, if we're not converting from T4 to T3 effectively. So you get low free T3, which is the effective, it's the active form of thyroid hormone in the body. It's converted in various places in the body. And selenium is one of those crucial minerals that's needed for that. Yeah, so your anion gap was low. And then copper may be represented by low uric acid levels and low hemoglobin. What about low stomach acid? Well, it's really interesting that in the NHS, because the whole of the health culture or medical culture is around quick fixes, and the whole of our culture is around quick fixes, because for example, we all want to be able to get on with our lives and ignore our health. That's the way our culture has developed over the last 50 years. And we want to just, if we've got heartburn, we don't want to have to stop going and drinking a glass of wine with our friends or eating out whenever we want to. We want a medicine that will stop us getting the heartburn. But in actual fact, a lot of heartburn is due to too low stomach acid, not too high. And then we go and manage that low stomach acid by blocking stomach acid production completely with omeprazole and lansoprazole, the quick fix drugs for that symptom, which then actually increases the problem because it's complicated. But part of the way the valve in the diaphragm works is because of the acid. And if you've not got enough acid, the valve is looser. And if it's looser, some of the acid can come back up and give you heartburn up the esophagus, when in fact the reason for that is too low acid, not too high. It's ironic, isn't it? Then you get H. pylori and other dysbiosis because you're not producing enough acid. So signs of low stomach acid include low levels of all of these markers and high levels of all of these. And urea or blood urea nitrogen, as it's called in America, can be either high or low with low stomach acid. Who would have thought it? I mean, Amy knows, she's an NHS trained GP on her own health journey, and we don't get taught stuff like this. It's all interesting. So pancreas inflammation can be represented, you can tell by there being poor digestive enzymes. So when you have poor digestive enzymes, you may have high levels of glucose and triglycerides and alkaline phosphatase. High levels of amylase is the only thing that we would know to measure in the NHS around this. Gamma GTP and low levels of albumin can also be due to poor digestive enzymes, because if the albumin is low, it suggests that you're not absorbing your protein well enough. So that could be due to low stomach acid, or it could be due to low pancreatic enzymes. And in this very uncomfortable looking pancreas here, pancreatitis is terrible, severe abdominal pain. Can be caused by alcohol, by gallstones, all sorts of things. So let's look at some of the cardiovascular markers. And here we got, we're looking, the routine cardiovascular markers we would look at. So if you get an NHS lipid screen, you'll get cholesterol, triglycerides, HDL, and LDL, although the LDL is actually calculated from the others. And then you may get what's called a Q risk, which is a calculated risk of heart disease or stroke. And it helps us to be more accurate with prescribing statins, basically, because we're instead of prescribing statins to everybody with a cholesterol over 5 or over 4, we're looking at people who have a higher risk because of the other risk factors like smoking and weight and blood pressure and family history, rheumatoid arthritis. All these things can impact your risk of heart attack or stroke. And as I say, yes. Oh, well done, Amy. Amy's declining to take lansoprazole, to the chagrin of her rheumatologist. Yes, so these are the routine markers, and there's a lot you can tell from them, but it's not as simple as might at first appear. One of the things about heart disease is that 50% of men, the first sign of heart disease is death, a fatal heart attack, and it's 60 to 65% of women. So, and this happened to my husband's best friend in 2020. He had a heart attack, went into a coma, never recovered. Absolutely heartbreaking because he was 52. And it comes as such a shock when I, as a GP, I remember a 42-year-old woman having a heart attack, and I thought, at the time, she was my age. Now I'm a bit older. So there are things that we can do to help with this. So some other cardiovascular markers that many of them we don't measure in traditional medical terms. In medical terms, we measure CRP, but we don't interpret it in terms of cardiovascular marker unless you're a cardiologist. The cardiologists are beginning to do that now. And I think the cardiologists also measure highly sensitive CRP, which is much better, more accurate. But in general practice terms, we're only looking at CRP as part of looking at what's going on in terms of inflammation in the body. Now, homocysteine is a great one. It's directly linked to risk of heart disease and stroke. It's often, as we've mentioned before, due to if it's a high homocysteine, it's often due to a B12 or folate deficiency. But again, NHS normal ranges still leave lots of scope for you to be sick. Oxidized LDL is something that we don't measure in the NHS. We learn about VLDL, which is very low density lipoprotein, but we don't really measure it. And apolipoprotein A and B, it's amazing what you can do with these tests when you're given the opportunity to go in it in more depth. But of course, it takes a lot of the practitioner time as well in interpreting and coming out with a conclusion, in addition to the extra test that's needed. So we can do that privately. And then fibrinogen also helps us to look at cardiovascular markers, and also the calcium CT score, which is something that's come up more and more lately in the last few years. It gives us a good, accurate level measure of cardiovascular age, which is great. So let's have a look at that advanced lipid profile with particle sizes. So it's a standard lipid panel, but then we add in these extra ones looking at the LDL pattern density and the subclasses HDL2, HDL3, and VLD1, 2, and 3, and then lipoprotein little a and apolipoprotein little b. So these all help us to have a much more specific approach to your risk for cardiovascular disease. And therefore to be treating the right people rather than just throwing statins at everybody, and being able to target lifestyle changes more accurately. For example, with B12 and folate supplementation, if that's what's needed. So let's look at the blood sugar. Ideal markers for fasting levels are 75 to 85 in US terms, and I've done a table with the UK terms later. Hemoglobin A1C, ideal markers 4.5 to 5, but we would be going sort of 6.5 for the A1C and it's for Western medicine level approach. And then the triglycerides in UK units, we want it to be less than 2.2, less than 2 really to be closer. And then insulin. Now, insulin's an interesting one. It's actually really helpful in predicting and in catching insulin resistance early because it goes high, but we don't measure it. I've never seen it as an option in my GP blood test requesting system, and we're so lucky to have that. I'm envious. I'm envious of that blood test requesting system whenever I'm doing private work. C-peptide is an interesting little peptide that joins 2 strings together that make the insulin. So if there's a high level of C-peptide, it means that insulin's being broken down. So it's all very helpful in looking at what's really going on with the blood sugars. Fructosamine and antibodies to insulin, islet cells, and GAD65. So of these, the only standard blood test ones would be the top 3. So here's where I've calculated the equivalent for UK. So it's the same table as we looked at earlier. But again, so if we look at here, the fasting glucose, we want ideally to be between 3.6 and 4.9 for fasting levels. And A1C 4.5 to 5. And in terms of the millimoles per moles that are used, certainly in most of the NHS now, we'd ideally want to be 26 to 31. Not wait until you're in the level of 41, because with diabetes, most people, by the time they're diagnosed with diabetes, when their HbA1c goes up to 49, they've already got retinopathy, retinal damage, so already got damage in the back of the eyes, damage in the kidneys, already got tingling fingers and toes, because of neuropathy, and that's because of that glycated hemoglobin I was talking about, which is a bit sticky, is getting stuck in the capillaries and affecting the nourishment of the oxygenation of the nerves, and that's why you get diabetic neuropathy. So you get nerve damage and nerve pains. Neuropathy can also affect bowel function, because you can get it affecting the way your bowel's emptying, the way your stomach's functioning, and so much more. So here's a bit more about HbA1c. I'm going to quickly look at those last two things. So well done, Vicky. So a random test in January 2022 was 4.8. Yes, so that's within the optimal range for, that's the glucose. So 4.8, yes, so you're still in the optimal range for that random glucose. And then, great that you brought your lab tests here for us to take. So Amy said you've only been able to measure insulin and C-peptide for patients in resus with hypoglycemia. Yeah. You just can't get these things in the NHS. So it's not your doctor's fault. And I don't want you brandishing a photograph or, a screenshot from this talk and going to your doctor saying, why aren't you measuring this? I've explained all the way through why that is. And even I, with everything I know about this stuff, I can't even request a free T3 level in a patient with an underactive thyroid. So don't blame your doctor, but take things in your own hands. Take this knowledge in your own hands. Okay. So here's the HbA1c. It's an indirect measure of blood sugars over a 120-day period, so 3 to 4 months. And the blood sugar attaching itself to these red blood cells like that, that's an irreversible. They can't come unstuck again. But because each red blood cell only lasts 90 to 120 days, that's why when you start improving your diet to reduce the blood sugar, you will see that impact after about 90 to 120 days. So we're not, again, allowed to recheck the HbA1c within 3 months. And to be honest, even if you're seeing us privately, it's not worth doing that, because it's only going to be after a longer period that you're going to see a difference. Although I have heard situations where that difference was seen sooner, because we've got constant turnover of these red blood cells, of course. So glucose gets attached to the hemoglobin in the red blood cell when levels of blood sugar are high, and that's irreversible. So again, these are US units, but basically a representation of the A1C over three, which looks at the blood sugar over 3 months, is representative of an average of over here of a day, your average glucose over that period of time. So we're looking at 4 to 5 being optimal. So we're looking at the average glucose not being higher than 5.4. So a lot lower than we usually use for diagnosing diabetes. It used to be, when we used this rather than the HbA1c for diagnosis, that a fasting glucose greater than 7 or a non-fasting glucose greater than 10 was a diagnosis of diabetes if it was repeated in the same thing again. So let's look at some of those negative effects of insulin resistance. I've referred to them a little bit already in terms of that spare tire around the tummy. Oh dear. Increased body fat, especially around the middle. And it's this body fat around the middle that's actually highest risk, because that means there's body fat nestling over the organs. And in actual fact, there are some diabetics who are already at high risk, even though they're skinny. You can get skinny diabetics who still have increased body fat around those organs within the tummy. But at the same time, measuring the waist circumference is a very useful marker, better than the body mass index that we tend to revert to, because we don't want to put our arms around a patient and measure their waist. I don't like doing that. It's a bit too intimate. But the waist circumference, waist to hip ratio is more effective for picking up this increased body fat around the middle. It causes damage to the blood vessel linings, elevated inflammatory markers, high blood pressure, decreased growth hormone and thyroid hormone, and also deranged lipid panel. So you end up with dysbiosis. You get more of the triglycerides and low-density lipoproteins and less of the HDL, the high-density lipoprotein, which is the beneficial. So after meals, the postprandial standard is to just measure it 2 hours after eating. So the maximum should be 6.1 in UK values. The ideal peak would be 5.49 to 5.5. But the ideal is for the blood sugar never to dip below the starting point, and so your blood sugar stays within a low level, even after meals. And that's impacted by what you eat, how you eat. So whether you're pausing and eating slowly and mindfully and breathing and getting into a parasympathetic state when you're eating, it's impacted by whether you sleep well. So those of us who have what's called by some of us voluntary insomnia, which means you're sort of up writing a talk for the next day till the silly hours of the night, that will impact your blood sugar processing the next day. And what I teach when I'm dealing with diabetes and pre-diabetes and insulin resistance is not just to have the blood sugar 2 hours after eating, which is what we measure in the NHS, or we tell people to measure, but to measure it every 15 minutes up to that 2 hours to see what your spike is, when your spike is, and how high it is. Because if it spikes to the level that's damaging your eyes, and yet at 2 hours it's back to normal, your GP is going to say, yes, that's normal. You know, you've got a good blood sugar control. But in the meantime, every time you eat, because it's spiking like that, you're getting damage to your eyes, to your kidneys, to your nerves. And we don't want that. So we've got another couple more sections to discuss, but I just want to pause here and share with you something that I found really useful, and that's a computerized printout that and computerized help with understanding your own labs. And we can do that based on your own labs that you've already got from your general practitioner, or we can arrange for you to have another set done. So this is the computerized blood chemistry support. It's really brilliant. You've seen how confusing all of these ups and downs are, these highs and lows. I mean, even with all my education, can't remember whether alkaline phosphatase means high zinc or low zinc, and all of these things. But what we do have is this brilliant system created by a naturopath, Dickon Weatherby, who created this computer system that brings out this wonderful report. And I'll show you some of the things that we can do with that. So as I've explained to you, functional ranges are different. So functional medicine ranges are very different to so-called normal ranges, and we can pick up things at an early stage. So this is part of the software. This is where we put the readings in. So I or my health coaches will add your actual readings to the software. We can choose here whether it's male or female template or conventional US or standard international use ranges, units. And we can also say whether they're fasting or not on that particular blood test. And then we just add the values in here, and as we add them, we can see whether they're optimal or standard. And then at the end, we then produce a report, which this is part of. So I love the blues, but they're not as graphic. They're not as motivating as the red-green version. So we can do it either of the two versions. And for example, with the fasting, you can see here, they mentioned this optimal and standard range. And when it's the dark blue, it's outside the optimal range. And when it's the very dark blue, standard range. Yeah, so that one is within standard range, but outside optimal range. And then this one, the paler blue, is within both. So that one's normal for both ranges. So you can see it's less easy than if you use the that color way, because you can see it's the traffic light system. Optimal is green, above or below optimal is amber, above or below standard is red, and then alarm is that's brighter red, that brighter pink. And when you look at the key, there we show again the alarm. There's the optimal ranges below or above optimal and below and above standard. And for each reading, you have it shows where you are in that range. So it shows whether you are within the optimal range or in the standard but not optimal range, or even above the standard. So this is the level here or here at which even your normal practitioner will say, yeah, that's abnormal. And so the benefits of this depend on how much detail we can put in. So if we actually have somebody who we have a fasting insulin and C-peptide value, we'll actually be able to get better results out of it. But even if you've only got a few blood tests to put in, we can come out with an amazing report that really helps us to support people going forward. So here, this is the blood test history report. And the great thing about this, which we don't really get to do in other circumstances, is we can see at a glance from here how it's changed over time. And we can put up to, I think, 7 tests will show on one screen with this. So although this one's got the latest 2 test results, I've had patients who've had 7 lab test results put in over time, and you can really see whether things are getting better or worse. So in this case, the fasting glucose has worsened a bit and the C-peptide has reduced, and the urea has gone up. So we sort of need to be thinking about, why is that happening? Why is the creatinine going up like that? What exactly is happening here? And you can see that these are between 2014 and 2021. So a long period of time has gone between these 2 sets of results. And then we look at the functional body systems, and here using the markers that we've already added, the software, the AI system will pick up whether you have thyroid dysfunction, liver dysfunction, immune function, and it also makes it very easy to prioritize. So in this patient, we know we're going to have to work on the thyroid first and the liver and the immune function. Blood sugar regulation we know is very important, but and probably more detrimental to the health. So we'd probably still in this one focus on the blood sugar regulation as well, but we're not needing to worry so much about sex hormone dysfunction and cardiovascular function in this particular case. And then these ones dysfunction is less likely. Now be aware, this is probability of dysfunction, it's not actual dysfunction. Just catch that. Yes, well done, Vicky. Okay, so nutrient status. So as well as where previously we're looking at organ dysfunction, so we're looking at things from an organ point of view. Here we're looking at vitamin status, protein status, and mineral status. So overall, we're looking at, yes, there's a high likelihood of vitamin deficiency here, and the protein and mineral status is not as we would like it. We'd like it to be less than 50. Fact, and so often these are blank if you've only got, as is often the case for my patients who just have their GP blood tests, we've only got liver function and full blood count and kidney function, those 3 in there. But each little thing helps. And for my blood test, we've only had thyroid function for the last few tests. And then within each one, as well as the bar chart, we also have a fan chart looking at thyroid function, which is very helpful. Then we can look at individual nutrient status. And this isn't that we've measured thiamine, magnesium, and DHEA, although we have measured vitamin D in this case, but it's that all of the markers that I've shown you can shine light on whether there is a zinc need and a B12 and folate need. So this would be represented by just there being a raised mean cell volume, for example, not that we've necessarily measured those actual markers. So it's amazing how much we can tell from standard blood tests. And then within here, the fan shape will tell us about the vitamin status and electrolyte status in more detail. So I wonder, would you like to know how to get this report run on your own blood test? So it can be very useful and life-changing, actually, and motivation-changing, can really help your motivation. So what would you like your help in understanding what your blood test report means with this sort of report, but also to know what to do about it? So what next steps you need to take to reverse those changes? Yay. So what I'm introducing today is the blood chemistry review consultation with that computerized report. So we get loads of information plus a review with myself or one of my health coaches. So what's included in this offer? And we're going to come back to the next 2 steps after this. So do hang around, and I've also got a prize at the end for anybody who stays till the end as well. I've got a special bonus. But we're going to have that computerized blood chemistry report that I've shown you that gives a detailed functional analysis of your existing blood test, identifying any potential organ and hormone dysfunctions and nutrient imbalances, and any follow-up testing recommendations. So, for example, with that thyroid result, it will say, actually, we recommend you get this free T3 done and the reverse T3, or actually you don't need those. So it gives us recommendations, which is great. And also included is a 90-minute lab review strategy session with me or one of my health coaches, where we'll discuss your health history, we'll get your questions answered, and we'll give you more tailored one-to-one direction based on the results of that lab test. We'll also do a food and supplement plan for addressing imbalances identified. And we'll also give you guidance on the most appropriate next steps for you, including any additional lab testing indicated, although lab test prices vary and are not included in the price of this program. So total value of that package is £900. And for those of you who are thinking, well, I really can't afford that, this is just, I don't have that sort of money, which nobody has that sort of money lying around. We don't keep that money, but it's about the direction of our spending. And I'd like you to consider how much your health issues are costing you, even if it's something vague. Like, we're so used to living in our culture with headaches and brain fog and sluggishness, but that could actually be slowing down from being more productive and achieving more in your life and really creating more. And creating more income. It could prevent you from having a raise at work and being promoted. There's also money that you're spending on your health at the moment. So if you're in a health economy where you have to pay at the time you see the doctor, there'll be extra appointments and medication that you may be paying for. And there's also therapists that you may be paying for, massage therapists and supplements. All of these are contributing to the costs of your health issues. And I'd like you to consider what your health is worth to you in these terms as well. And it's not just your current health either, it's also your future health. So we're looking at optimizing your risks of heart disease, stroke, and dementia in the future, and diabetes, as well as your current health issues. And those of you in our generation, we have had parents who have become ill, maybe even died, like my own. And you've seen your parents or aunts and uncles with long lists of medication that they're on, with a lot of pathology, with dementia and heart disease and the sequelae of strokes and cancer. So as a result of this blood chemistry review, you'll be able to identify imbalances before they actually become diseases. Now, this isn't to make you anxious and panicky, it's to make you feel into what you want to change and why you want to change it, and give you that motivation, because I have seen time and again that people won't make lifestyle changes unless they can see that there's actually a need for it. And this is what will help you to see the need and therefore change things so that you reduce your blood pressure, so that you're not needing all those medications, etc., etc. It would also help you to identify nutritional deficiencies and toxic excesses, identify immune system imbalances and prevent illness. So it'll help support your resistance against infections that might be buzzing around as well. Identify potential digestive imbalances. So I've referred a little bit to things like the acidity, and our stomach acid and pancreatic enzymes. It will identify inflammation and correct it before it becomes serious. So inflammation can be in the joints, it may be in the muscles, it may be within your gut itself. Helps to identify causes of low energy. And so many people, as I say, are walking around with brain fog, headaches, exhaustion. It can also give you a roadmap of what your next best steps should be, because you could see how easy it was to prioritize your focus when you saw those readouts. So what's included in this are that computerized blood chemistry report, which helps you identify dysfunctions, that 90-minute lab review strategy session, a food and supplement plan, and guidance on your next appropriate steps. So the value is £900. Usually it's £750 for this. And I have a special offer for those of you who are watching this masterclass and the recording. This is a special offer that's only available for a short while, just a few days. If you put in the code BCA353 to that website, you'll get the special offer of £397 for that. Okay. So let's have a look at the last two sections of this analysis of what you can see, what you can pick up from your blood tests. Let's look at anemia. So anemia, there are many different types of anemia. The image there with these sickle-shaped cells, this is sickle cell anemia, which is a hereditary genetic thing. So people who have sickle cell anemia are actually resistant to malaria. So they're not impacted by malaria as badly as people who don't have it. However, it can lead to difficulties. So the commonest anemia that we see is iron deficiency. And this we can see as microcytic. It has small red blood cells. Micro means small. So the red blood cells are smaller than usual. So these ones here, they're smaller in diameter. Then there's macrocytic anemia, which may be either folate or B12 deficiency. There may be other things too, but they're usually folate or B12 deficiency or alcohol excess. And that's when the red cells are larger than usual, which usually means that they are young red cells, because when red cells are first produced, they're larger and they've got a nucleus, and then the nucleus goes away and the red cells reduce to the normal size. B6 deficiency can also cause anemia. Hemolytic anemia, which is when you've got hemolysis and the red cells are hemolyzing, which means they're bursting. And then we have aplastic anemia, which is basically bone marrow dysfunction, can be caused by drugs. With aplastic anemia, you've got a lack of white blood cells as well as red cells. So you've got, as well as feeling exhausted all the time, and we'll come to the symptoms in a moment, you'll also be more prone to infections. And sickle cell anemia and thalassemia. Thalassemia is like sickle cell anemia in that it's a genetic problem, and you have, with both sickle cell and thalassemia, you have sickle cell trait and thalassemia trait. Thalassemia, you have alpha and beta thalassemia. But with thalassemia, you tend to have small red cells again. And then anemia of chronic disease, which is also extremely common, which is basically if somebody has chronic renal disease, liver disease, they often have a general anemia, but it's not actually due to iron deficiency. We check their iron, we check their folate and B12. They're all normal. It's just something they've got to live with, but it leaves them a little bit more prone to tiredness. So these are some of the symptoms that we see with anemia: fatigue, weakness, headache, shortness of breath after exercise, and chest pain. Now, this is very interesting to me because how we diagnosed my mum's anemia was because she started getting angina. And it was actually caused by the anemia. Yes, she had the heart disease going on in the first place with the narrowed blood vessels, but because of the anemia, not enough oxygen was getting to her heart. And once she had an iron infusion, the angina went away. So it's really interesting the way these things are all linked. Pounding in the ears and these other symptoms as well: palpitations, dizziness, cold hands and feet. So with that angina, you can have a heart attack where the prior cause, although there's the thinning in the arteries, the narrowing of the arteries already, but the cause is the anemia because there's not enough oxygen getting where it's needed. So let's look at those important anemia blood markers. First of all, the number of red blood cells, hemoglobin level. We now, they've changed things in the last couple of years in the National Health Service, so it's now times 10. So it's now 135 to 145, for example. The reason why women's normal ranges tend to be less than men's for a lot of full blood count markers is because women are having periods, and so they're losing a lot of blood. And as a result, they don't tend to suffer from hemochromatosis, which is a genetic tendency to having too much hemoglobin, because they're losing every month. They only develop symptoms after the menopause. Then there's the hematocrit, the mean cell volume, which I've talked about on several occasions. The red cell distribution width. Now, the reason this is important is because, as I mentioned when we talked about B12 and folate deficiency, when you've got young red cells, they're larger. And so when there's a wider, this is a distribution of sizes of red cells. So if you've got some that are small and some that are large, the distribution of them is larger, and that's where you see when there's a lot more red blood cells being created by the bone marrow. More iron deficiency blood markers, the iron level, ferritin, transferrin, which transports iron. Ferritin is the storage form of iron, but it's also an inflammatory marker. Total iron binding capacity, which is the available transferrin to bind the iron, and the transferrin saturation, which is how much iron is actually bound to transferrin. So these are more in-depth iron markers that we can request in the NHS in certain situations. So if somebody is anemic, we can request more in-depth iron studies, and likewise we can request further studies if the hemoglobin is high. So there's a risk of hemochromatosis. So some of the causes of anemia: pregnancy is very common. Worms and parasites, autoimmune disease, heart disease, chronic infection, and chronic kidney disease. Medications, so anti-inflammatories, for example, can cause gradual gastritis and bleeding constantly from the stomach. And that's why my mum had her anemia. Her anemia was because of, it wasn't actually anti-inflammatory induced. I think she had her aspirin and things stopped, but it was medication induced initially. And then serious illness, and as GPs, we're always alert. If somebody has anemia that there isn't an obvious explanation for, we have to have them checked out for cancer. And that's one of the priorities as a GP in the Western medical system. It is our priority to make sure we pick up as early as possible anything really serious like that. And you will understand how important that is. And then these other things, so heavy menstrual bleeding or menorrhagia, internal bleeding. So we need to know where that's coming from. It can be just from piles, hemorrhoids, but also commonly, coming back to here, a common cause of anemia in older people over 50, as young as that, is bowel cancer. So we do need to be looking a bit closer sometimes. So the progression of iron deficiency anemia, I'm not going to spend much time on this bit, but when initially you have just a decreased iron stores, so the ferritin will be low. Then you develop to having decreased iron as well, so the serum iron will be low. Then you have iron deficiency anemia, where you've got iron and ferritin and mean cell volume low and the hemoglobin low. So anemia means literally that the hemoglobin is low. And then there are other situations where the numbers may be skewed. And this is something, again, that we don't learn about in traditional medicine. But if you've got a high iron and a low ferritin, it can be that you have a low melatonin level. If you have a high iron and a low hemoglobin, it may be that you have a B6 issue. And there may be liver inflammation if the iron is low and the ferritin is high, because ferritin is also this acute phase protein like CRP. So it goes up when there's inflammation going on in your body. And then high iron and high ferritin is a sign of hemochromatosis. So it does merit more in-depth studies. And remember, if you have patients whose blood tests are outside even the NHS type, the Western normal ranges, it's important to refer them back to their own doctor to have any further investigations that are needed. And while still working with, it's important for you to still work with us to correct things, but we will always be looking out for that. And then B12 and folate anemia, the main thing is this increased mean cell volume. Other things may be normal or even decreased. And then anemia and serious illness. So these are things like cancer. We need to be looking for the TIBC and transferrin may be normal or increased. There'll be other symptoms and other findings. And these are the other reasons that could be a cause of that. So it could be just protein depletion, which in turn could be due to reduced stomach acid, for example. Kidney failure is common. So make sure you get that you see your own doctor again if you're noticing these and they've not picked up on it. Because sadly, we do have to look through these blood tests in a hurry and we may not spot things. Okay, anemias of excess. Polycythemia was when the red blood cells and hematocrit are increased and you have a high hemoglobin. And it just means increased numbers of red cells. The classic example is polycythemia rubra vera. So there are different sorts of polycythemia, maybe autoimmune. And then hemochromatosis, which is this genetic condition. Now, the reason it's important that this is picked up and managed is that it can lead to cirrhosis of the liver, and it can even lead, and then that you can develop diabetes as a result of that. You can need a liver transplant as a result of that. So we women are somewhat protected by having periods, and it's important to get this checked out. Let's look at the immune system. So one of the things that helps us with the immune system is the full blood count, known as the complete blood count in America, with differential white cells. So we're looking at the different subsections of the white cells. For example, if there's a raised number of neutrophils, it can be a sign of a bacterial infection. If there's a raised number of lymphocytes, it can be a viral infection. And then monocytes can be a sign of the recovery stage of inflammation and chronic infection. Basophils are a sign of allergy and histamine, and eosinophils are often a sign of allergies like asthma and also parasites. So bacterial infections will tend to have white blood cells, particularly neutrophils. They may be high. Lymphocytes may be low because the body's concentrated on the neutrophils, which are going to attack these little blighters. And then with viral infections, they tend to have low neutrophils and high lymphocytes, although I do sometimes see a low lymphocyte level in a viral infection. And then there's chronic as well as acute viral infections to consider. And then parasitic infections may show high white blood cells as they're trying to attack the parasites, and eosinophils are the main one. And then inflammatory markers showing that there's inflammation going on in your body. CRP, then there's the highly sensitive C-reactive protein, which we don't necessarily do in the NHS. I don't think I have access to it, but we do with more private blood tests, and you may be able to through your general practitioner. And then the ESR, homocysteine, these are important inflammatory markers. And then extras that we can test for the thyroid, of course. So the thyroid is a world of its own. I'm going to be giving a masterclass just on thyroid, and I've got a whole course on it. So thyroid, so Western medical doctors, we're really only allowed to check the TSH. This is in systems that are rationed, okay? In a system like in America where you can say, I want you to get these blood tests and I will pay for it, then you can ask for some extra blood tests. But even with everything I know, I can't request the free T3. So ideally, I'd like to be able to do TSH, total T4, free T3. Even in the NHS, we can do the thyroid peroxidase antibodies, but we can't do thyroglobulin antibody, whereas it's ideal to be able to measure both. Most underactive thyroids in the Western world is due to autoimmune hypothyroidism or Hashimoto's thyroiditis. And then there's the reverse T3, which is it's when the T4 is turned into reverse T3 instead of T3. Reverse T3 is like a mirror image of normal T3. T3 is the active form that gets your metabolism going, gives you the get up and go, and helps control your weight gain and all of that. Reverse T3 does the reverse. The reason it's important, the reason our body is perfect, and the physiology is amazing. It's doing that to slow you down. So you'll get a high level of reverse T3 when you've got a viral infection or when you've got chronic fatigue, because your body's trying to slow you down to recover. So it's a bit of cause and effect there, but it can help you to understand what's going on. So you can take control of your own health. I have access to this spreadsheet that quickly allows me to highlight what could be causing things, but the blood chemistry printout, that report goes into it in even more depth, so it's great. So just to recap, the blood chemistry report, which can help us to really see into your blood and see what's hiding there that you're not aware of, that can help you to really optimize your health. And we can put into that so many different blood tests, including sex hormones and thyroid hormones if you've got them. And it helps us to work out what's going on at a really deep level and see whether there are dysfunctions going on, like low stomach acid, in this case, thyroglobulin antibodies. You see, the value was 10. Now, in the NHS, normal will be anything above 11 or 30, depending on which antibody. Yeah, blows my mind. So back to the TSH for Vicky and for me. Ideal is between 1.3 and 3. But although the Western medicine has been taught to make a big fuss if it's below 0.7, and doctors get struck off for keeping someone's thyroid TSH below 0.7, in actual fact, that's out of date information, and in fact it's not high risk. But if you have an overtreated hypothyroid person, or if somebody has thyrotoxicosis that then declining to have the strong chemotherapy drugs that treat it, you can lead to osteoporosis, you get hyperactive, you get tremor, and you can have a heart attack because you're just increasing your metabolism too much. So we do want it to be within the optimal range if possible. And then if somebody's got infertility related to an underactive thyroid, in infertility worlds, you really want your TSH to be below 2.5. So we even got tighter optimal levels for that in an ideal world. And remembering that there are all these other things that we can put in, and that we can look at things over time as well. It's just a brilliant additional tool that I have in my toolkit. And here's some of the detail. For example, this is with the fan bit, the fan type display. We see all of this detail about the thyroid. It tells us why it's decided that you have thyroid dysfunction. In this case, there was a raised TSH, a low free T3, a raised thyroglobulin antibody, and raised TPO antibodies. They've also considered additional biomarkers. So it might say in here if they've used other things as well. And also it says, consider running in future the T3 uptake, free thyroxine index, thyroid globulin antibodies, thyroid peroxidase antibodies, so a different one, and free T3. So looking at it tells you what to do to look at things in more detail, even more so with the liver here, which it points out that fatty liver, which is so common now. And in the NHS, we just say, yes, your ultrasound shows you've got fatty liver. That's all. We don't do anything. I actually give them a leaflet that explains fatty liver, but most doctors don't. And we don't tell them what they can do to reverse it, because I only discovered that you can reverse fatty liver through my work in nutritional endocrinology and functional medicine. In traditional medicine terms, you can't reverse fatty liver, you can't reverse diabetes, but there's so much we can do. You can, if you take back ownership of your health, change so much. And there's me looking at some results. And there's the nutrient status, the individual nutrient status, the clinical dysfunctions that looks at the different organ systems, and these blood test results. And then again, with the practitioner result, we also have a bit more information under each one as well. So it's great. So how to get this report and to consult with Dr. Ali, with me and one of my coaches. There we go. So total value is £900. And as a result, if you remember, we're identifying these imbalances before they actually become diseases. We're identifying nutritional deficiencies and toxic excesses. We're identifying immune system imbalances and helping to prevent illness. And we're identifying digestive imbalances, inflammation before it becomes serious, and causes of low energy. And we have a roadmap of what your next best steps should be. So remembering what your health issues are costing you at the moment and how that's impacting you. And I see so many people who work like anything, and then they spend all their money on their health afterwards because they've not got balance in their lives. And we really need to invest in our health from an earlier age, in terms of supplements, in terms of good food, in terms of balance, and in terms of getting this early help to see what's going on. So if you go to drali.com/lab review and put in the code, here's the code, BCA353. BCA353. This is a time limited code. It's only going to be in for a few days. and that will give you that discount. So, and here is the bonus that I said I would give you. It's a perimenopause labs cheat sheet. It's actually it explains some of the lab tests that you can get. It's not just perimenopause, actually. It's relevant to men as well. It outlines some of these lab tests like the full blood count and the biochemistry we've talked about. And it's a cheat sheet. So go to find that. You go to drali.com/lab bonus. There, and lab review for the actual package. Okay. Right. So have you got any questions? I'll just stop the recording.